Hello, everybody. This is Dr. Al Heuer. I'm a professor at Rutgers University in beautiful Newark, New Jersey. I am co-owner of A&T Lectures. I co-edit multiple respiratory care textbooks, including Egan's Fundamentals of Respiratory Care. I'm coming to you today to give a brief, approximately 30-minute presentation that begins to introduce you folks to pediatric PFTs, pulmonary function tests. We'll look at some special considerations and we'll examine them in action by reviewing 2 case studies. Hope you enjoy this presentation. Hope you learn something from it. And hopefully you'll come back to A&T Lectures for your continuing education needs in respiratory care and nursing. Let's take a look at some learning objectives. We basically boiled down this presentation into 4 broad learning objectives. Firstly, we're going to review major indications for performing pulmonary function tests on pediatric patients. We'll examine special considerations for performing them in this population. We'll review selected cases, 2 in particular, and I'll provide you guys with additional resources should you want to drill down and learn more about this topic. So when considering a procedure, very important to understand the primary indications, why we're performing that procedure. In this case, why we're performing pulmonary function testing on a pediatric or other young patient. So the major considerations are actually fairly similar to those indications in adults. We're looking to identify the presence of and severity of obstructive and restrictive disorders. We're also trying to monitor the progression of the disease state by, if you will, performing serial, okay, so over a series of months or years, pulmonary function tests. This can be particularly useful in tracking, if you will, the effectiveness of the treatment plan and unfortunately the progression of the disease in diseases such as cystic fibrosis. Look at the response to therapy, and in some cases it may be if that cystic fibrosis patient is holding their own, if you will. They're really complying with the care plan, that their deterioration may be very, very gradual. Or if an asthmatic patient is adhering to the treatment plan, they and of course their parents if they're a pediatric patient, to see that they're maintaining their flows adequately and their perhaps response to bronchodilator therapy, the pre and the post. So it'd be very, very useful in looking at those particular areas. In addition, however, for this patient population, also PFTs can also provide some useful data on lung growth. Okay, lung growth. Now we talk about young patients. We could be talking about infants, young toddlers, young adolescents, older adolescents. So I deliberately, and I did a little bit of cherry picking here, but I deliberately took a look at some of the special considerations in this particular slide for infants and young toddlers. So this patient population, they're generally not capable of following directions, generally require the infant to be sedated. Again, that in and of itself can be very can be challenging in and of itself because infants may respond to sedation very, very differently than adults do. Even though adults need to be closely monitored with moderate sedation, infants need to be even more so. So again, formal and sedation protocols should be established. Anesthesiology and an anesthesiologist is generally present, especially in a less stable patient requiring IV sedation. So things like, narcotics, Seconal, if you will, is one of the medications that can be used, but it's a fairly powerful medication and needs to be used with great caution. Toddlers, on the other hand, may be sedated with an oral agent such as chloral hydrate. And again, I'm just throwing a typical dose, if there's such a thing, would be 50 to 75 milligrams per kilogram of ideal or predicted body weight. Feeding should be held for 4 to 6 hours before the chloral hydrate is administered. Therefore, the need for testing should be pervasive because of all of these precautions, if you will. Monitoring should be vigilant during the procedure, and those that are monitoring, the patient care team need to be really astute and watching out for, if you will, effects like apnea or loss of a patient airway, which are possible with various forms of sedation. Rescue protocols must be in place, including having a crash cart nearby. Now, building on the special considerations, infants for up to 1 year, their lung compliance can be measured passively by what's called the passive occlusion technique. And it really is, based on Boyle's law where, there's a change in volume over change in pressure. So something to consider is that the Heuer reflex accounts for infants up to 1 year to hold their breath when their airway is occluded. Now, we obviously don't want them holding the breath for any long period of time, but this could be useful. During that single breath occlusion, alveolar pressure can be measured via a pressure transducer. So this is where we're using a natural, if you will, reflex to actually obtain some potentially useful values. When the valve opens, the infant passively exhale and volume can be measured. Airway resistance can be measured from the same basic maneuver. Now, moving on to toddlers, 2.5 to, let's say, 3 years old, chest wall becomes more rigid. The Heuer reflex is lost, therefore passive occlusion technique is probably not possible. However, they may be able to follow basic instructions. They may also be able to tolerate simple passive procedures without the need for sedation. And again, this needs to be, the patient needs to be assessed in advance, and this needs to be determined on an individual patient basis. Some additional special considerations for children that are over 3 years old. So children as young as 3 years old have the potential to perform spirometry. Up to 50% can actually perform it. Okay. Trust must first be gained. So think about you work in a pediatric unit, irrespective of what you're doing, you need to gain the trust of the child. Nose clips are pretty much a must. With the appropriate training, introducing spirometry to children as young as 3 to 5 years old can yield remarkable results. Practice blowing on a pinwheel can be one technique that can be used. The biggest challenge in preschool children is maintaining exhalation after the initial blast. The American Thoracic Society, or ATS focus group recommendations include the following. Identify premature termination of, if you will, the exhalation by comparing flow at termination to peak flow. Report the highest at forced vital capacity and FEV1. Due to their small lungs, extrapolated volume may exceed 5% or the 50 ml ATS guideline, and values as high as 80 mLs or 12.5% may in fact be acceptable. So if you will, there's kind of a loosening of what, ATS guidelines of what we would regard as an acceptable study in the younger patient population. Now, by age 5, on average, most children can perform spirometry with adequate technique and repeatability. So regarding conditions or diseases which warrant PFT, so this kind of complements the slide on indications, but it gets a little more specific. So asthma, cystic fibrosis, certain neuromuscular diseases in this population, in particular SMA or spinal muscular atrophy, but we could argue that diseases like muscular dystrophy and other similar diseases can also warrant doing serial pulmonary function tests. Other diseases or conditions, so status post bronchopulmonary dysplasia, vocal cord dysfunction, bronchiolitis obliterans, pulmonary fibrosis. Folks, pulmonary fibrosis is not common in this age group, but it can occur. So it's not a common indication, but it's something to be aware of and keep on the radar screen. So now let's take a look at the first of two cases that I've included in this presentation to try to illustrate, a few of the points and just overall illustrate some of the common indications and trials and tribulations and interpretation involved in pediatric pulmonary function testing. So the first is, as you guys can see here, is a cystic fibrosis patient. He's an 8-year-old boy seen by the CF or Cystic Fibrosis Center since his diagnosis. Spirometry has been routine performed. This is again our serial pulmonary function tests, not during an exacerbation because you really want to get the patient's baseline. But certainly if the patient had an exacerbation and that was resolved, then you'd probably get pulmonary function testing a few weeks after the patient's been stabilized. Complete set of PFTs is obtained, I say annually, maybe it's at least annually, including lung volume determination. So there's a lot of information on this slide. Okay, this is the actual printout of this patient's pulmonary function testing. Okay, just to look at it at a glance, it could be overwhelming. Okay, in the interest of time, I really want to focus on the information that's in the upper right, and then the information after that in the lower left. So in the upper right, we basically have this patient who's got, they've done spirometry on them. They have the best as far as forced vital capacity of 1.09. And that's kind of that, if you will, the top line of that upper right there. This individual is able to do 59% predicted. And then the patient gets a breathing treatment. They wait a reasonable interval and they repeat the test. And the percent predicted goes from 59 to 63. Again, the top line, upper, if you will, right-hand side there, for a 6% change. So generally speaking, that's not regarded as a significant response to bronchodilator. Doesn't mean this patient shouldn't get bronchodilators. It just means that their underlying condition, CF, is not going to have a big reversible component, unless there's something like asthma superimposed on top of it, okay? And then you have some of your other, the FEV1 and the FEV1 percentage in the lines, again, upper right-hand side, in the lines beneath that. And then they actually, again, so we really don't have, the percent change, okay, is negligible. In some cases, it's actually in the negative category. But really, the take-home theme is, slightly positive, slightly negative, but does not respond to bronchodilator therapy, okay? The other thing I really want to point you to, and I'll do this with the other case study, is that the graphic in the, if you will, lower left-hand portion. So you get your flow volume loop, okay? And in this particular case, you could see that there's several, just regular breathing, demarcated by that kind of the center portion of the flow volume curve. And then you have the patient take a deep breath in. Again, the low beneath the line is inhalation, above the line is exhalation. And then out. Okay. So let's look at what the actual graphical, what the numbers actually mean in the lung volumes. So vital capacity, again, predicted 1.84. The, if you will, actual value is 1.17 or 63% predicted. Total lung, again, capacity is 2.59. The percent predicted is, it looks like 2.88 for 111% predicted. Okay, and so on and so forth. So what we're taking home from this is that now vital capacity. The funny thing with that is it's a vital capacity, so it's really volume over time or a flow. Okay, it gets a little bit confusing. All right. But the balance of them, total lung capacity, residual volume, etc., are all above normal. And we'll talk more about that when we interpret it. So again, what you have is, in this particular patient, is decreased flows, but they're not responsive to bronchodilators. I'm taking a lot of information in this slide. I'm trying to simplify it. And then again, going down to the lower left, you also have, with one exception, you have fairly significant if you will, hyperinflation. So let's take a closer look in the ensuing slides of the interpretation. So what does this all mean? Again, a lot of some graphics, a lot of interpretation, a lot of numbers in the preceding slide. Let's try to boil it down. Again, interpreting pulmonary function tests is not, it's something that requires not just kind of reviewing, academic material, textbooks, that sort of thing, but it requires even doing it, and requires things like reviewing videos like this and the many, many other fine videos that are out there on, the performance of and interpreting pulmonary function tests. So let's take a look at this question regarding this case. Okay, what information does a spirometry alone provide? So there is a proportionate and moderate decrease in both forced vital capacity and FEV1. The ratio of FEV1 to forced vital capacity is within normal range. Basically, FEV1 to forced vital capacity is what percentage of the total forced vital capacity can the patient exhale in 1 second. Okay, and we're really looking for somewhere in the 70s, depending upon which book you look at, around 75%. So roughly, two-thirds to three-quarters of that breath should be exhalable in the first second. All right, but when you have forced vital capacity and FEV1 both reduced, so they're reduced to a similar proportion, so that percentage is relatively constant. The third bullet point, additionally, FEF 2575 is decreased to a greater degree. And remember, FEF 2575, really you're looking at peripheral, very small airways. Okay, so that's decreased to a greater degree. And the tailing off, if you will, of the flow volume loop is a clue that airflow obstruction is, more, affecting a patient at lower lung volumes. So that's suggesting, think about what happens at lower lung volumes. That's the air, the gas that's being exhaled from the peripheral airways. So CF is a disease process that results in progressive and significant airway obstruction. And note that the degree of airway obstruction in the small and peripheral airways can be more profound. That's just something inherent in the disease. So let's take a look at another question regarding the same case, the cystic fibrosis patient. What additional information is revealed by lung volume determination? So that was really emphasizing flows. Subject's lung volume measurements by body plasmography, the body box, rule out any thoughts of a restrictive disorder. The TLC is normal, so the patient is not restricted, and the forced vital capacity, residual volume, and the residual volume to total lung capacity just suggests significant air trapping, The combination of reduced forced vital capacity, FEV1, and yet substantially elevated RV, or frankly, they're concerning for an 8-year-old with CF, so a relatively young patient with cystic fibrosis. Furthermore, lack of improvement post-bronchodilator suggests little to no, if you will, response to bronchodilators. Again, doesn't mean that they shouldn't be given, but the benefit is going to be, less than what we'd see, for instance, in the next case we're going to look at. Note sometimes that subjects with CS will improve after bronchodilator, but that's also coupled with aggressive coughing due to mobilization of secretion. So it's not bronchodilation, it's we've been able to mobilize secretions, and that's really aided, in some of these patients, post-treatment. So two final questions we're going to look at regarding case number 1 is, does the spirometry meet ATS criteria for acceptability? So I hinted at this kind of earlier on in the presentation. So examination of pre-bronchodilator time volume graph indicates that strict ATS criteria were not reached. The subject's expiratory time did not reach 6 seconds, and a clear flow plateau may not have also been attained. But here's the rub. Although ATS criteria are more important goals, small children may not be able to achieve this exact criteria. Repeatability of the efforts is crucial, but a 6-second expiratory time and a flow plateau are not. So again, we kind of look at the interpretation in view of acceptability from ATS criteria more liberally, than when we would with adults. The last question before we move on to the next case study is, what is the final interpretation of this PFT? So it looks like there's a symmetric and moderate reduction in FEV1 and forced vital capacity. We're just saying that they're both, if you will, reduced to about the same degree. without a response to bronchodilator. Not surprising in this condition. The TLC is normal, however, residual volume and RV to TLC are significantly elevated, which suggests air trapping and intrathoracic airflow obstruction. The patient's oxygenation is adequate on room air. It's a bit borderline, but again, it is indeed adequate. So this is not surprising. What I will tell you, though, is for an 8-year-old with cystic fibrosis, it's a bit disconcerting. It suggests that they have significant impairment relative to their young age. Now let's move on to the next case study. This case involves a 9-year-old girl who's been treated for severe, persistent asthma since she was young. You could argue she still is young, but since she was younger. Her asthma medication regimen includes Singulair, so that's a leukotriene inhibitor, Advair, albuterol PRN, and Flonase. She occasionally requires prednisone during acute exacerbations. She's also been hospitalized on several occasions, including admission to the PICU. She's only 9 years old, and she's been hospitalized several times. Not a good finding. This patient is notable in that she's rarely been known to wheeze or have any asthmatic symptoms during clinical visits. The following PFTs are typical of her routine clinical visits. Let's take a look. So again, not trying to dazzle you folks. There's a lot of information on this slide, but like we did with the other case, let's keep it mainly concentrated on the upper right, where we actually have our spirometry, and the lower left, which are our lung volumes. Okay. So again, not surprisingly, you have this patient whose spirometry, again, upper left, the before bronchodilator, they have a, if you will, a 90-something% predicted, and afterwards it's 103. Okay, that's the forced vital capacity. It's a 14% change. For a good rule of thumb would be 15%. I've seen some of the books say as low as 10% would be a significant change. Some of the books said 20. So in that mid-teen range or greater would be a significant response to bronchodilator. The FEV1, by the way, which is less effort dependent than a peak flow. FEV1, on the other hand, yields a 58% change, 58%. So pre, it was 52% predicted, post it's 81, significant. And then you have some of the others as well. The, FEV1 to forced vital capacity, as well as some of the others, really notable response to bronchodilators regarding flows. Now let's look at the lower left, where we have the flow volume loops, if you will. And I will tell you this, I'm going to tip my hand and say that they are, they're, if you will, not just notched out, but if you look at the horizontal axis, which is really time, the patient is still exhaling. They're exhaling longer. So it's really, and there is a carve out there, a notch, which is typically found in obstructive patients that have obstructive disorders. Now, not surprisingly to me, maybe it is to you, you look at the lung volumes. Because this patient has significant airway obstruction, they're air trapping. And that air trapping can be seen in that lower left. Vital capacity is 177 predicted. Total lung capacity is 257%, is 2.57 predicted. If you will, the residual volume is 67% predicted. So they're really elevated, and really is all owing to air trapping. And we look at the next several slides. We'll talk about that in more detail. So to kind of summarize what I just said in the preceding slide, how should the spirometry and lung volume measurements be, before bronchodilators be interpreted? So pre-bronchodilator spirometry indicates moderate intrathoracic airflow obstruction. Flow volume loop is a classic concave, which I just, the notched out, if you will, look, or very scooped expiratory pattern, owing to, again, the obstruction taking longer to exhale out. Forced vital capacity is normal range. However, the FEV1 to forced vital capacity are significantly reduced. The airflow obstruction is further confirmed with lung volume determination. Note, total lung capacity is higher, the higher end of normal, 113% predicted. So again, generally speaking, 80 to 120% predicted is normal, but obviously this patient's kind of is getting closer to, if you will, being higher than above that 120% predicted at 113. Significantly, her functional residual capacity, her residual volume and residual volume to total lung capacity are high. That's owing to their air trapping, just by the way. The subject's expiratory time is prolonged at about 10 seconds. So most patients you'd figure 5, 6, 7 seconds. They're up to 10 seconds. Oxygen saturation on room air is adequate but mildly reduced. What changes are seen after bronchodilator therapy? So again, we have a significant 58% improvement in FEV1. There's a shift to the right in position of the flow volume loop after bronchodilator, which shows the reduced TLC and residual volume. Although the medical regimen prescribed to treat her asthma in this patient is aggressive, the dramatic response to bronchodilator calls into question her compliance. So she's almost like she's naive to taking bronchodilators. So when she takes it, she gets this big old response. Subjects who do not feel short of breath, do not wheeze, do not perceive that they're having any asthmatic symptoms, tend to forget to take their medication. Simply put, they're not compliant. Repeated visits to the PFT lab with similar results suggest that the patient may not be using their medications nor adhering to the treatment plan as prescribed. So what can we speculate or hypothesize in this case? So, the chronic airway obstruction is a concerning sign in a subject, a 9-year-old patient. May be suggestive or indicate that remodeling of the airway due to the presence and persistence of inflammatory mediators may well be occurring. These chronic changes, especially combined with her questionable adherence to the treatment plan, may indicate that she, will have some more significant, and it may become non-reversible airway obstruction in the future. Not saying it's going to happen, but it's certainly a key that it could. So coming down the home stretch here, some concluding thoughts, take-home points. PFTs can provide valuable clinical data in all patient populations: infants, pediatrics, adults. The indications for PFTs, however, in younger adults is somewhat similar to those in older adolescents and adult patients. However, there's many special considerations which must be viewed when considering performing and interpreting PFTs in these younger patients. Failure to recognize and account for these differences can endanger patients, waste resources, and contribute to misdiagnosed and flawed treatment plans. It's a mouthful. Proper consideration of such unique aspects can promote better patient care and enhance clinical outcomes. This short presentation, I get it, it only scratches the surface on many unique considerations for pediatric PFTs, but we hope it encourages you to learn more in this area. Lastly, I wanted to share with you some selected resources. Rupel's Manual of Pulmonary Function Testing is as useful to pulmonary function testing as Egan's is to respiratory care. So Carl Moltran does an excellent job with Rupel's Manual of Pulmonary Function Testing, and I strongly push you in that direction if you want to learn more about it. Egan's Fundamentals has a chapter on pulmonary function testing as well, as does my clinical assessment and respiratory care textbook. Also a good reference would be the American Thoracic Society PFT Interpretation Guide, published in 2022. So with that, I want to thank you guys very much for joining us today. Hopefully you got something out of this presentation, and hopefully you will come back to us for your continuing education needs in respiratory care. Thanks a lot, and have a wonderful day.